All right, a little recording here. Fix that box. There we go. A little recording here about cardiomyopathy. I've got 4 different diseases that I'm talking about: dilated cardiomyopathy, restrictive cardiomyopathy, concentric hypertrophic cardiomyopathy, and hypertrophic obstructive cardiomyopathy. So let me talk really briefly about what these are. First of all, dilated cardiomyopathy. So this is essentially where the heart gets really dilated. Okay, so dilation means it gets kind of big, it gets kind of floppy. Kind of imagine like a big floppy dilated heart. It's all floppy, it can't contract very well, that kind of problem. Restrictive cardiomyopathy, this is where there's some kind of like fibrosis or something around it that's not allowing it to open up as much as it needs to, so it's kind of tight, like it's got something encasing it almost. Concentric hypertrophic cardiomyopathy, this is basically where you have hypertension that's been going on for so long and is so bad that the muscle has had to push so hard to get the blood everywhere it needs to go that it's basically becomes super muscular. And you think, oh, that's great, I got a super muscular heart. But no, that's not good. If it gets that muscular, it actually becomes so bulky, it's almost like those weightlifters that can't like take their shirts off because they can't reach the back of their shirt. It decreases its ability to function properly because it's so muscular from having chronic hypertension. And lastly, we have hypertrophic obstructive cardiomyopathy. This is a genetic disease where there's just a specific part of the heart that's really big, and so it's kind of like bulging in some weird area, and so that ends up obstructing something important, like a place where blood can get in or out. So it's a bad deal. So let's talk about each one of these. So the patient comes in this situation, they're going to have systolic congestive heart failure, orthopnea, crackles, edema, paroxysmal nocturnal dyspnea. This is a bad deal. If someone comes with these symptoms, you might start thinking about having dilated cardiomyopathy. Pathology of the disease, we're looking at here, of course, the decreased contractility I was talking about. It could be from a virus, or maybe from alcohol, or maybe it's ischemia. How are you going to get the diagnosis? You're going to do an echocardiogram, and when you do an echocardiogram, you're going to see, oh, the heart's all dilated. That's not good. And how are you going to treat it? Well, beta blockers, ACE inhibitors, have them stop taking alcohol if they were. You want to avoid chemotherapy, and you want to consider maybe giving them a transplant. All right, next one here, restrictive cardiomyopathy. So in this case, remember we were talking about the heart can't move properly because it's got so much like fibrotic material in there or whatever. So in this case, they've got diastolic congestive heart failure. And there's 3 types here I mentioned. There's amyloid. If they have amyloid, or go into what that is, you can look it up somewhere else, they're going to have some kind of neuropathy most likely. And if it's sarcoid, then think of the acronym here, ASH, okay, amyloid, sarcoid, and hemochromatosis. So if it's sarcoid, it could be also, they could have some sort of pulmonary disease. And usually, if I remember correctly, the sarcoidosis, you're thinking of patients that are not white. For some reason, non-white patients seem to get this more often. I think females more often than men. So I think one of the common presentations I saw for this was like an African female, or African American or black, whatever. So then hemochromatosis. This is, I'm not going into the disease right now. Cirrhosis and diabetes mellitus. So that's restrictive. So pathology, there are some of them here. Diagnosis, echocardiogram shows restrictive. So you do an echo, oh yeah, their heart's not able to, it's restricted, it's not moving like it should. How do you treat it? Similar thing, beta blockers, but on this one also get calcium channel blockers, kind of a gentle diuresis with these people. Maybe consider a transplant. And if they have like sarcoidosis or amyloidosis or hemochromatosis, you need to make sure you fix the underlying diagnosis. That's because that's what's causing this, right? The restrictive cardiomyopathy is really a symptom of some other problem. Okay, the next one here is concentric hypertrophic cardiomyopathy. So this is going to show up as a diastolic congestive heart failure. If you notice, I think all these were diastolic except for the dilated cardiomyopathy. And which kind of makes sense if you think about what's happening during diastole and systole. So in this case, the pathologies, they just had hypertension. They had chronic hypertension for such a long time, their heart had to push so hard to get the blood into them. You should do the echo. It's going to show, all right, yeah, they have concentric hypertrophy. All little spaces in their heart should be really small because they're so full of bulging muscles. And you want to avoid dehydration. You want to give them beta blockers or calcium channel blockers, maybe consider a transplant, and again, fix the hypertension. That's kind of the key here. Get that heart to relax a little bit. Okay, next one, the last one here is hypertrophic obstructive cardiomyopathy. So in this one, you're going to hear a murmur. It's going to be a young athlete. They're going to have dyspnea on exertion, and they're going to have syncope, and they might have some family member who had sudden cardiac death. Now, if it's a patient, hopefully they're not already dead. But if someone did, someone dies and they're like, what caused it? You might consider that being hypertrophic obstructive cardiomyopathy. What's the problem here? It's a genetics problem with the sarcomeres, okay, with a little structure in the muscles. And you're going to do an echo, and you're going to see, yeah, there's one part of the heart that's kind of asymmetric, where it's really hypertrophied. And how are you going to treat them? We're going to avoid dehydration, beta blockers, calcium channel blockers. Maybe you could use alcohol ablation. It's basically we take a needle and you ablate this one area, and the alcohol kind of kills it, and it kind of like shrinks down a little bit. That's usually only used though if they weren't a good candidate for surgery. If they're a good candidate for surgery, then you can use a myectomy, which is where you go in there and cut out part of the heart muscle. Make sure after with these people you screen for relatives. Now the issue with these people, it's kind of sad. It's young athletes. They're probably gonna have to stop. They're gonna have to stop doing what they're doing because it's making their heart big, and it's too dangerous. And that concludes that lecture.